Hello, everyone. This is Chadi Alraies coming to you from RSH 2026. I'm privileged to be with Dr. Benoy Shah to talk about a very important topic about asymptomatic severe AS. Dr. Shah, thanks for being with us and welcome to Riyadh.
Thank you, It's nice
Yeah,
to be with you.
yeah. So this is a very important topic. There's some literature, some trials have took place, and yesterday you did a phenomenal debate about the topic. So, what is the current state, and what should we manage? How we should manage the patient with asymptomatic severe AS?
Thanks. Yeah, so you're right that we have had obviously a huge trial with the early TAVR trial in the last 12 months coming out. I mean, before that, we only had two relatively small surgical trials. We had the recovery trial and the Avatar trial, both of which suggested that patients would do better with early surgery rather than watchful waiting. But these were very small trials, and so we didn't, as a community, really feel that we had enough data to make a class one recommendation of that. And plus, those were both trials of surgery. And of course, with an increasing number of our AS patients receiving TAVI, was the same going to be true for transcatheter valve replacement? Early TAVR looked at 900 patients and randomized them to either watchful waiting or early intervention.
Surgery or TAVR?
So just TAVR. Just
Just
TAVR.
TAVR, okay.
Yeah. And it was just TAVR with the Sapien platform, so balloon expandable valves only. And we know that they did a pretty good job of being sure that they were asymptomatic because 90% of the patients were able to complete an exercise treadmill test, and they had a negative test, negative for symptoms, negative for fall in blood pressure. So it was a pretty well characterized population. And what was really interesting in the trial and what's generated a lot of debate is that at the follow-up that they presented, the intervention in the early group had not led to less death or to less heart attacks, but it led to less unplanned hospitalization. And that's what's caused a lot of interest and discussion because the trial sponsors defined unplanned hospitalization as including those patients initially randomized to watchful waiting who had then got in touch to say, I've now got symptoms. And they were planned to come into the hospital to now have a TAVI, but because it wasn't part of the original plan, it was defined as unplanned.
Unplanned, I see.
But I think actually, to be fair, when you now put all of the data together, you've now got these three trials, all with a signal suggesting earlier intervention. And I think that's definitely something we need to be looking at more now as a community.
And the follow-up period was 1 year?
Correct. Yeah.
So there is no change in mortality when you watch?
Not at 1 year. Not at 1 year. I mean, I think that undoubtedly we know that severe aortic stenosis, can unfortunately sometimes be associated with sudden death. And we also know that that's more likely the more severe your stenosis is. So I think that, certainly if you look at patients that have what we call very severe stenosis or critical stenosis, peak velocity above 5, so your mean gradient above 60, etc. I've never practiced watchful waiting in that cohort.
Because they drop dead.
They're high risk, and they need to just have that valve treated.
Absolutely. So now, based on what you have in the debate yesterday, and as you said, the trial was not powered for the outcome, which is scored favorable at that domain. What should we do now in 2026?
It's a really good question. And I think that one of the things we talked about in the debate was that there's probably no single correct answer to that, depending upon where you work and what is your ability to deliver valve intervention in a timely manner. So in the early TAVI trial, the time to getting the TAVR was 14 days. That's unheard of. People were saying that even in the biggest center in the States, you won't get a TAVI in 14 days. But we do know from so much data accumulated over decades that as soon as you become symptomatic with severe AS, you can go downhill quite quickly. So I think the thing with watchful waiting is you can do it safely if you see patients regularly, but if at the point the patient then comes to clinic and says, I'm now symptomatic, I had to stop twice to catch my breath just walking to this clinic from the car park in the hospital, and at that stage you then say, okay, great, I'll list you now, it's a 9-month wait for intervention. That's bad.
Right.
So watchful waiting, I think, only really works if you are in a healthcare system where you can deliver the valve intervention quickly. So, within the UK, we have struggles in some parts of the country. And, in my center, the waiting time for TAVI is long. It's more than half a year. So I'm very reluctant to do watchful waiting because I'll often say to people who say they're asymptomatic that you may be asymptomatic now, But actually, by the time you get your treatment, there's a good chance that you will be symptomatic,
Yeah.
or that your ventricular function may be beginning to deteriorate.
Yeah.
And so we don't have the ability to deliver TAVI that quickly. So I don't do watchful waiting in that setting, in most patients, because I can't deliver it quickly enough.
Yeah. So a question for you, or at least I don't know if you have a recommendation. So because in this trial they did exercise testing, do you recommend like to do that exercise testing at a certain interval to determine if the symptoms are triggered early so you can enlist the patient?
Absolutely. So I think that we know, even though it's been in the guidelines for a long time, exercise testing is still underutilized. And I do it a lot. It's a modified Bruce protocol those patients should do, not the
Simple.
standard Bruce.
Yeah.
And people say, oh, but some of the elderly, yes, some of the very elderly can't exercise. But actually, if you do a really gentle protocol, you can still see who becomes highly breathless within 1 minute. And I've had a few patients just in the last year or two that had really quite significant falls in blood pressure on exercise. 2 of the 3 patients I'm thinking of were actually asymptomatic from that, but they completely dumped their blood pressure with exercise. And, rightly, that is clearly a sign that there's a
Exactly.
hemodynamic problem.
And the
And
LVs.
I referred them for intervention, and they're doing great. So I think that we should do it. If you do it, and the patient says that they're asymptomatic, and then they decide they want watchful waiting, they don't want to be referred yet, then I see them every 6 months. And in an ideal world, you would actually treadmill them every 6 months if you have the capacity to do that.
Yeah. Which is also 6 months for me is kind of
Yeah,
a long period of
it is.
time.
It is. So you have to be sure. You have to be sure that your patients understand.
Yeah.
I mean, so all of our patients have our clinic's contact details, email address, phone number. We tell them, look, don't come to that 6-month appointment and say, oh, I've been struggling for the past 2 months. You're meant to get in touch
Yeah.
as soon as you start getting a problem. If there was a distance that you did from your home to the local shop or something
That's it.
that you were previously doing fine, and that now you're finding don't wait to the next clinic appointment, just get in touch.
The other challenge I have, especially this is an elderly population, older, not elderly, they go in the US, we don't have a centralized health system. So they say in winter, they go to Florida to spend the winter,
Okay, yeah.
and we lose follow up, and they go
Yeah.
for 6 months.
Yeah.
Maybe they're going to get sick there and get
Yes.
admitted, and the doctor, oh, you have severe aortic stenosis.
Yes. Yeah.
So they lost that kind of structured follow up system that you created.
Yeah, and I think that as a valve community, we've probably made a little bit too much of watchful waiting.
Yeah.
And, it is a very, very different disease to mitral regurgitation.
Right.
For mitral regurgitation, where it's a volume load on the ventricle rather than a pressure load, you really can genuinely watch these patients for years
Right.
if you watch them very closely. I always say to my patients with aortic stenosis, let's just say they're 72 years old, 73, right? I say to them, look, we're not going to get to 80 here by watchful waiting, okay? We're talking about maybe procrastinating by 18, 24 months at the max. And when you explain that to most patients will actually say to me, well, doc, if there's a problem, should we just get on and fix it?
Exactly.
Whilst I'm younger, whilst my procedural risk is lower.
Yeah.
And that, most people
Makes sense.
are switched on enough to realize that.
Yeah.
So
just one last comment to clarify: like, if somebody has watchful waiting and he's becoming symptomatic, you refer them to the structural heart team to determine whether surgical or TAVR, right?
yeah.
Yeah, because I want to make sure, because the early TAVR was only TAVR. I want to clarify to the audience that you detect the problem and you put them in the pipeline for structural heart team.
Yeah, exactly that. And then depending on which country you work in, you'll have
Yeah.
different thresholds for whether they're for surgery or for TAVI. But yeah,
Absolutely.
I mean, yeah.
Well, that's great debate and great cover. I mean, this is a great summary actually after what we have so far from literature. Thank you, Dr. Shah, for your input, and thanks for watching these videos. And this is Chadi Alraies coming to you from Riyadh Structural Heart 2026 in Riyadh. Dr. Shah, thanks again.
Thanks, Chadi.